Welcome and thank you for standing by. At this time, all participants are in a listen-only mode until the question and answer session of today's conference. At that time, you may press star 1 on your phone to ask a question. I would like to inform all parties that today's conference is being recorded. If you have any objections, you may disconnect at this time. I would now like to turn the call over to Helen Taylor McCray. Thank you. You may begin.
Hi, thank you, Chelsea. Good afternoon, everyone. My name is Helen Talley McCray, and I work in the One Health Office of the National Center for Emerging and Zoonotic Infectious Diseases at the Centers for Disease Control and Prevention. On behalf of the One Health Office, I'm pleased to welcome you to the monthly Zoonoses and One Health Updates call on August 7th, 2019. ZOHU call content is directed to epidemiologists, laboratorians, scientists, physicians, nurses, veterinarians, animal health officials, and other public health professionals at the federal, state, and local levels. Please be aware that CDC has no control over who participates on this conference call. Therefore, please exercise discretion on sensitive content and material, as confidentiality during these calls cannot be guaranteed. Today's call is being recorded, so if you have any objections, you may disconnect. Detailed instructions for obtaining free continuing education, are available on our website and will be given at the end of this call. These presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. The Planning Committee reviewed content to ensure there's no bias. CDC did not accept commercial support for this activity. CDC, our planners, presenters, and their spouses or partners disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Before we begin today's presentations, Dr. Casey Barton-Baravish, Director of CDC's One Health Office, will share some news and updates.
Hi, everyone, and thanks for joining us for today's ZOHU call. Welcome to all of our new participants. The ZOHU call audience has around 1,400 subscribers representing professionals from government, non-governmental organizations, industry, and academia, as well as students. We appreciate your help spreading the word about the ZOHU call. Please continue to share the ZOHU call website link with your colleagues. The site includes information on call recordings, information on free continuing education for a variety of professionals, and a link to subscribe to the ZOHU call email list. To begin today's call, I'd like to share highlights from the One Health news from CDC, which are included in today's ZOHU call email reminder. CDC is conducting a survey of large animal clinical practitioners across the United States. The goal of the survey is to understand the circumstances and challenges large animal veterinarians experience when evaluating an abortion event in livestock. The information gathered will assist the CDC and partners with targeted veterinary education to decrease occupational exposures to zoonotic infectious disease, and this survey is open through October 31st, 2019. Some new resources that are available online include that CDC has released the 2020 Yellow Book, which provides health information for international travel and includes the new One Health chapter. CDC's updated information about taking action to prevent the spread of flu between pigs and people. And the OIE has posted information about the eradication of bovine tuberculosis, a One Health issue. Some upcoming events of interest include a One Health conference in Harris County, Texas, a Zoobiquity conference here in Atlanta, and ID Week in Washington, D.C. Also, from October 27th through November 1st, the 30th annual RETA, Rabies in the Americas Conference, will be held in Kansas City, Missouri. On today's call, of note, we're going to hear about a case of rabies in a dog imported from Egypt. And then the Inform 2020 conference is happening in March. That's the Integrated Foodborne Outbreak Response and Management Conference. Abstracts for that are due September 15th. Several recorded presentations have been posted online, including the CDC Coca-Cola webinar, multi-drug resistant Candida auris, an update on current U.S. epidemiology, clinical profile management and control strategies, and a recent CDC webinar about emerging issues in tick-borne diseases. We've also shared some recent publications, including a new OIE scientific and technical review titled Successes and Remaining Challenges Within the One Health Approach, also a special issue of Foodborne Pathogens and Disease on the National and International PulseNet Network, and the August EID Journal has several articles relevant to One Health. In MMWR, there's a Japanese encephalitis vaccine, recommendations of the Advisory Committee on Immunization Practices, and in notes from the field on the targeted biomonitoring for Gen-X and other per- and polyfluoroalkyl substances following detection of drinking water. There are several outbreak notices that have been updated, including an outbreak of multi-drug resistant salmonella infections linked to contact with pig ear dog treats, outbreaks of salmonella infections linked to backyard poultry, and a multi-state outbreak of salmonella infections linked to hedgehogs. There's a selected list of ongoing and past U.S. outbreaks of zoonotic diseases, as well as information on staying safe and healthy around animals on CDC's Healthy Pets, Healthy People website. And the complete CDC current outbreak list, as always, is available at cdc.gov/outbreaks. If you would like for us to share news from your organization, or if you want to suggest presentation topics, or even volunteer to present, please contact us at zohucall@cdc.gov. Again, thanks for supporting the ZOHU Call and for joining us today. I'll now turn the call back over to Helen.
Thank you. Today's presentations will address one or more of the following objectives. Number one, address 2 key points for each presentation. Number 2, describe how a multi-sectoral One Health approach can be applied to the presentation topics. 3, identify an implication for animal and human health. 4, identify a One Health approach strategy for prevention, detection, or response to public health threats. And 5, identify 2 new resources for CDC partners. Questions for all presenters will be taken at the end of the call. Please call 1-800-593-8936 and enter participant passcode 9611836. Press star 1 and give the operator your name and affiliation. Please name the presenter or topic at the beginning of each question. You'll find resources and links for all presentations on our website and in today's ZOHU Call email reminder. Our first presentation is basically it's a co-presentation, so just bear with me. I'm going to skip to another slide and then we'll get started. Just one moment. Great. Sorry for that pause there. Our first presentation, Case Report Review of Rabies in Imported Dogs, will be given by Drs. Ingrid Garrison and Kendra Stauffer. Dr. Garrison, please begin when you're ready.
Good afternoon. On the evening of Saturday, February 23rd, a veterinarian called KDHE, the Kansas Department of Health and Environment, to report a dog suspected of having rabies. The dog displayed increased aggression, bit a veterinary technician on February 21st, and had worsening neurological clinical signs. The dog was humanely euthanized that day, and brain tissue was submitted to the Kansas State University Rabies Laboratory on Sunday, February 24th. It tested positive for rabies by direct immune fluorescent antibody test on Monday, February 25th. The submitting veterinarian stated the dog had been imported from Egypt. The specimen was sent to CDC for variant typing and was identified as Egyptian Cosmopolitan Canine variant on Friday, March 1st. Clinical signs began on February 20th. The next evening it began vomiting and adjusted a blanket. It exhibited neurological signs and the dog was taken to a veterinarian at Hospital A where it became aggressive and bit a veterinary technician. The dog was transferred to the veterinarian at Hospital B on February 22nd and surgery was performed due to an observed obstruction on ultrasound. On February 23rd, the dog was laterally recumbent. However, it developed increased aggression and attempted to bite upon any sound or touch. Investigation revealed the dog was imported from Egypt by a pet rescue group on January 27th. It was flown into Canada and then driven to Kansas City to the pet rescue on January 28th. The pet rescue imported a total of 26 dogs from an animal shelter in Egypt. All the dogs were fostered or adopted by people in Kansas or Missouri. We notified the Johnson County Health Department, the Kansas Department of Agriculture, the Missouri Department of Health and Senior Services, and CDC. Documentation for the dogs was reviewed by the Canadian authorities upon landing in Toronto, at the border crossing into the United States, and by the Kansas Department of Agriculture upon arrival at the pet shelter in Kansas. All dogs had appropriate documentation for the following: certificate of veterinary inspection and rabies vaccination certificate. Although not required for entry into the U.S. or Kansas, the dogs had also had documentation of rabies serology that showed an acceptable rabies vaccination titer. All dogs were missing a USDA APHIS animal care permit, which is required for adoption or commercial sale of dogs in the United States. A rabies risk assessment, exposure assessment was conducted on all people and animals that were in contact with the dog 10 days prior to the onset of clinical signs on February 10th until the dog was euthanized on February 23rd. The Hospital B corporate office informed all of their staff of Hospital B to receive post-exposure prophylaxis. This message was sent prior to evaluation of staff by Public Health. A total of 46 people received post-PEP. 12 dogs in the foster home of the rabid dog were considered exposed. 2 were unvaccinated and were quarantined for 6 months. The remaining dogs were currently vaccinated, received a rabies booster vaccination, and were observed for 45 days. The rabid dog had been at the shelter in Egypt for about 3 years prior to importation to the United States. Existing dogs at the Egyptian shelter were commingled with other dogs arriving from the streets. There was no information to indicate an obvious exposure to rabies at the Egyptian shelter. Rabies in a vaccinated dog is rare. This rabid dog, along with previous similar incidents of rabid dogs imported by rescues from Egypt into the United States, led us to question the validity of the remaining dogs' rabies vaccination status. We determined the remaining 25 dogs could have been exposed to the same source and required them to be quarantined to protect human and animal health. The Kansas Department of Agriculture determined the pet rescue could serve as a quarantine facility for these dogs. The length of the quarantine was determined through prospective serological monitoring called PSM, which was included in the 2016 National Association of State Public Health Veterinarians Rabies Compendium and adopted into the Kansas Rabies Control Regulation. PSM can be used to evaluate evidence of previous vaccination of a dog or cat. For dogs whose results showed evidence of receiving a previous rabies vaccine, they would undergo a 4-month quarantine. If the results show that they had never received a previous rabies vaccine, they would undergo a 6-month quarantine. A veterinarian checked on the dogs weekly, and the Department of Agriculture and Johnson County Health and Environment and local animal control made periodic unannounced visits to also check on the dogs. The PSM criteria is as follows. A serum specimen is drawn first. The dog is vaccinated with a licensed rabies vaccine per label. The second serum specimen should be drawn on days 5 to 7. In this case, all 25 dogs have the second serum specimen pulled on day 5. Both specimens are sent to the lab at the same time, and the dog remains in quarantine until the results are available. If the paired serum specimens show a statistically significant rise in titer between the first and second specimens, and the second titer is greater than 0.5 international units per mil, then the dog is considered to have evidence of previous vaccination. A dog is also considered previously vaccinated if the first specimen was greater than or equal to 0.5 international units per mil, which indicates a previous vaccination response is ongoing. The results must be interpreted in conjunction with the lab performing the test. For example, the K-State Rabies Lab considers a statistically significant rise between the first and second specimen as 1.8-fold increase based on the analysis of their lab's data. So again, not only having this documentation of these levels, but also interpreting the results with the lab is very important. So the results showed that there were 7 dogs that were considered previously vaccinated. They had a 4-month quarantine, and they were released on May 29th, and they all survived. However, the majority of the dogs in this group that was imported from Egypt were not previously vaccinated. They had a 6-month quarantine, and they were just released on July 9th. All dogs survived. We followed up with the 3 different vaccine manufacturers that were listed on the rabies certificate for these dogs. All vaccine lot numbers were verified by the manufacturers. We were unable to contact the director of the Egyptian lab that performed the initial serology on the 26 dogs. The canine rabies virus variant was declared eliminated from the United States in 2007. According to the Federal Register, more than 1 million dogs are imported into the United States each year, and more than 100,000 of those are from countries considered at high risk for canine rabies virus variant. This is the 3rd instance of a rabid dog imported from Egypt by a rescue group in 4 years. CDC has determined that until appropriate veterinary controls are in place in Egypt, a rabies vaccination certificate is not sufficient to protect U.S. public health against rabid dogs being imported from Egypt. And for this reason, under the Code of Federal Regulations that Dr. Stoffer will talk about here shortly, they have exercised a temporary suspension of dogs entering the United States from Egypt. And CDC is working on a long-term management solution to this problem. So we have many people to thank for their help in this investigation. Most of them are listed here on the slide, but it truly is a One Health effort. And as Dr. Barton Baravesh had mentioned, the Rabies in the Americas Conference is being held in Kansas City for the first time at the end of October. Abstract submissions are open until the 11th of this month, so we hope to see you there. And I will answer questions at the conclusion of this hour.
Great. Thank you, Dr. Garrison. Just bear with me again, folks. I'm going to go back to the beginning for Dr. Stauffer's presentation. One moment.
All right, good afternoon. And as Dr. Garrison said, so I can skip through some of these first slides. She talked about the suspension that CDC put in place in May, and it was a result of the 3rd case in 4 years of a rabid dog from Egypt. And this was basically instituted because of the failure of the veterinary controls in Egypt to prevent the exportation of rabies. One thing I do want to mention that Dr. Garrison did not talk about is what we wrote into the Federal Register notice is what's called an advance written approval. And this did allow for dogs that originated in the U.S. and then went to Egypt and then now were coming back to the United States. So basically this meant that they could apply for an importation permit to come back into the United States. And so it is very restrictive. So even though there is an import restriction and essentially a ban put in place for any dogs originating or transiting through Egypt, we are allowing for dogs to come back that can prove that they have been fully immunized against rabies. And so we're requiring rabies vaccination certificates from the U.S., and if they cannot provide that, we are requiring titers from an OIE-approved laboratory. And what I want to talk about today is what we've learned since the ban, because I think this is kind of important. So the breakdown, so the ban went into effect the middle of May. And these were the permits issued as of July 31st. So far we've issued 57 permits. 29 had rabies vaccinations given in the United States. 27 went through the process of submitting rabies titers from an OIE-approved laboratory. And then we did have one that was allowed to enter with the post-titer testing that Dr. Garrison talked about. And this was underneath approval by the state public health veterinarian of the state where this came into. And this was only allowed because the dog was literally caught on the day of the ban when it was supposed to be exiting Egypt. So who is applying for these advanced written approval? We had 10 United States government workers returning home, and then we had 15 U.S. citizens or legal permanent residents returning for non-government jobs. And what struck us as unusual and kind of took us by surprise is that we also had 32 that were just on travel or vacation, meaning they were just temporarily in Egypt and wanting to come back. So interesting findings based on this import restriction is we had quite a few rescue groups coming out in the media saying that CDC has paralyzed the rescue groups' ability to move dogs out of Egypt. And we also were shocked, like I said, by the fact that there are a lot of short-term travelers, more than we ever thought. And these are just people that are going to Egypt temporarily. They take their dogs with them, and then they want to return home to the United States. And also, it has become apparent that we knew that there was some fraudulent document going on, as the Europeans had reported it before, but there's many countries that have come out since we put this ban in place and said you're not alone with dealing with the fraudulent documents and the rabid dog imports. So where are we heading? What are we doing? So we formed an interagency working group, and we met twice monthly, and this is made up of subject matter experts between our federal and our state partners. And we're looking at adding a fourth category called the high-risk restricted group. So currently we have the no known risk group, the low-risk group, the high-risk group. This would be an additional category which would require additional restrictions. And then what we would do is publish our new guidance in the Federal Register. But this is still ongoing. We just moved through the first technical science part of the working group, and then we move into other aspects as we hope to get this guidance out in the next few months. Web resources for folks that did not know about the Federal Register. This didn't have enough time to go review the entire thing, but I provided some web resources for folks if you're not familiar with the ban and the case reports. And then Dr. Garrison's group will be publishing the 2019 case soon, and so we'll add that to the list of resources when that becomes available as well. I did want to mention that as a request from the state, because of our change in policies over the year, they did request that we do more, CDC do more notification at the ports of entry. So we do have these flyers now out with CBP officers, Customs and Border Protection officers at the ports of entry. They are in English, French, and Spanish. And so they are handed out to every person regardless if they have even if it's at the Canadian land border crossing, and at this point in time they do not need to have any documents to be able to come into the United States as far as rabies vaccination certificates, they will still get one of these flyers as they cross to let them know that there's state and local requirements. And with that, I have to acknowledge again a whole team of folks both at the state level and here at CDC that help with these rabid dogs coming in from Egypt. And I will also take questions at the end of the session. Thank you.
Thanks, Dr. Stauffer. Again, I'm going to have to just really quickly move on to the next presentation, so just bear with us one moment.
Hi, everyone.
Hi, sorry, Dr. Negron. So our next presentation, Brucella abortus RB51 infections in humans caused by consumption of unpasteurized domestic dairy products in the United States, is by Dr. Maria E. Negron Saruda. Please begin when you're ready.
Hi, good afternoon, everyone. As Helen said, my name, I'm Maria Negron. I'm from the Bacterial Special Pathogens branch here at NCCID. And today I'm going to be giving you an overview of on raw milk in the United States and the risk of acquiring this through consumption of raw milk. And then I'm going to give you a level summary of the 3 cases because Dr. Leslie Serafin will go into more detail on some of those cases. Since July of 2017, the CDC has received notification of 3 confirmed cases of Brucella abortus RB51, which is the cattle vaccine strain. At least 8 other individuals fit the probable case definition, and this means that they had a clinical compatible illness with brucellosis, and they also had an epidemiological link. Although we know that the RB51 strain can cause disease in people, as we see this that happens in veterinarians and vet techs due to vial breakage or injection of the vaccine accidentally. These 3 cases that we're going to be talking about today are the first 3 documented cases of RB51 due to consumption of a pasteurized dairy product acquired in the United States. So before we get into these investigations, we first need to understand the raw milk regulations in the United States. In Michigan, 71 years ago, they enacted the first statewide requirements for milk pasteurization. And then almost 40 years later, the FDA banned the interstate distribution of raw milk. But what we need to understand is that the states are the ones who regulate the intrastate sales, which brings a lot of variability into the mix. Regulations can go from a complete ban, and they can go all the way to being able to sell raw milk in stores. And then to complicate matters a little bit more, we've seen in the past decade an increase of raw milk sales online, which is very difficult to regulate. So then studies have shown that raw milk-related outbreaks are more common in states that allow the legal sale of raw milk. And as more states continue to change the regulations to allow these sales, we're seeing an increase also in the number of raw milk outbreaks, which have increased from 30 to 51 outbreaks in a matter of 6 years. Most of these outbreaks occur as a result of intrastate sale of raw milk, and they cost on average 60 illnesses per year. And overall, between 2007 and 2016, there have been 144 raw milk associated outbreaks across 32 states. Now, we have to change gears a bit, and we're going to start focusing on Brucella. Brucellosis is a bacterial illness that is one of the classical zoonotic diseases where people only acquire the disease by either contact with infected animal fluids or through consumption of unpasteurized dairy products. And if we know this, then the next logical question is there a risk of acquiring Brucella through consumption of raw milk in the United States? But then to answer this, we first need to look at what are the existing and what were the disease dynamics before and what are the disease dynamics now. So because of the success of the cattle brucellosis eradication program in the United States, and because most of the milk is being consumed after being pasteurized, not only human brucellosis in the United States is rare, but the dynamics have switched. Before, we mostly considered this to be an occupational disease, and also we saw cases because of consumption of raw milk products. And basically now what we see here are cases that are mainly hunters, feral swine hunters in particular, and also people who travel to endemic countries, and also people who work at diagnostic laboratories. So what we need to think about is on the different Brucella species and whether or not they exist here in the United States or if there's really a. So when we look at Brucella melitensis, it is highly unlikely that you would see that there is a risk of acquiring Brucella through consumption of unpasteurized milk from the United States because we don't have Brucella melitensis in the United States and we don't vaccinate for it. On the other hand, when we look at Brucella suis, it could be possible, especially from cattle where you have, you know that they're commingling with feral swine. As cattle can be infected with Brucella suis and the bacteria can be shedding milk. However, the spread within a herd will be very limited. So then the next species that is Brucella abortus, which primarily affects cattle, what we need to start thinking about is whether it will be the field strain versus the vaccine strain. So from the field strain, the disease is only present in wildlife around the Yellowstone area, and then we do vaccinate cattle in the United States with RB51. So Brucella abortus RB51 is a live attenuated vaccine to prevent brucellosis in cattle that has been used in the United States since 1990s. And as I mentioned before, it is known to cause disease in humans, but they were mostly due to needle sticks and bile breakage. And even when used according to label recommendations, it is possible for cattle to shed RB51 in their milk. And this is another reason why we should always consume pasteurized dairy products. So in the next few slides, I have the three, like a very high-level summary of the three cases. And Dr. Serafin will cover the last two in more detail. The first investigation that we did, it was in Texas in 2017. There was a confirmed case, and there were at least 4 other probable cases. And there were people from 7 states who reported consuming raw milk products from the implicated farm. Texas led a call center and CDC assisted them where 397 households were contacted, and we provided exposure notification and testing, PPE recommendations, and treatment recommendations. The next case, a few months later, CDC was notified of a second case in New Jersey, completely unrelated to the Texas case. This was different because in this particular case, it was reported that the milk was acquired through Uttermilk, which is an online retailer, and that they were selling products through multiple states in the Northeast. For this reason, the number of people exposed was not known, and we were not able to confirm the implicated farm at this point. And then the third case, we need to forward a year later, so 2018, and we received notification of the third case, this time in New York. And the source was a raw milk dairy in Pennsylvania, and approximately people from 19 states were exposed. Originally, we thought that the New Jersey case and the New York case were unrelated, but during the investigation, it was identified that the farm was selling raw milk products through Uttermilk, during the period that that the second case from New Jersey happened. So unfortunately, there are many challenges that were identified or highlighted throughout all of these investigations. First, RB51 is an attenuated strain. However, it can cause infections in people, especially in individuals who are pregnant or immunocompromised. Diagnosis of RB51 in humans is limited to culture, as commercially available serological tests do not detect antibodies to RB51, and this can be extremely problematic if the patient has already received antibiotics. Because brucellosis is not very common in the United States, in addition to the non-specific symptoms, this disease is not the first thing that may pop up in physicians that may think about when cases present to their offices or to the ER. And then also, this strain is resistant to rifampin, which is one of the main antibiotics used to treat brucellosis in conjunction with doxy. And then finally, raw milk consumption is increasing throughout the United States, which leads us to where we go next. CDC recommends that public health and regulatory authorities continue to support pasteurization and consider further restricting the sale and distribution of raw milk and raw milk products in their jurisdictions. Definitely we need a joint approach to halt internet sales of unpasteurized dairy products as well. We need to continue to increase awareness, communicating about the public health risks associated with drinking raw milk, and also to continue to disseminate in the medical community the challenges associated with RB51 infections and RB51 exposures. And we need to continue to promote the One Health and multi-level collaboration and communication. I think these 3 investigations were a prime example of how a One Health team works throughout an investigation. And we continue to work together because we're revisiting the guidelines on the use of RB51 vaccines and screening of cattle herds. And as I said before, this is like a multi-agency, also multi-level at the state, New Jersey, Pennsylvania, New York State, Texas, and multiple groups within also our partners in USDA and DSL. And I'll be happy to answer any questions at the end of the phone call.
Thank you so much. Our final presentation, Brucella abortus vaccine strain RB51, New Jersey and New York, One Health Issues and Finding the Source Herd, is by Dr. Leslie L. Serafin. Please begin when you're ready.
Okay, I don't see my slides yet. Do I just advance? There we go. Okay, thanks. So I am an epidemiology officer with USDA Veterinary Services in District 1. And at the time I was covering New Jersey and Pennsylvania. So a little bit of this I think Maria kind of went over, but prior to the USDA taking on brucellosis eradication efforts, B. abortus caused infections in humans at a rate of over 6,000 cases a year. Now it's rare with 80 to 120 cases a year, mostly in Brucella exposed people that got exposed abroad, Pasteurization has greatly decreased the number of human cases, and states began eradication in 1934, and USDA began eradication of B. abortus in 1954. It was eradicated from U.S. cattle around 2000, but it is still in wildlife in the greater Yellowstone area with occasional spillover to cattle. So how did we get the cases to decrease? Well, part was via surveillance. It's slaughter, interstate testing movement, bulk tank samples, testing bulk tank milk samples for Brucella, and also calfhood vaccination. The vaccine is modified live, and it's a mixture of B. abortus strains. And what happens is you vaccinate the calf, and the calf mounts an immune response and clears the infection. Now we're finding that it seems some cattle don't clear the infection, but may shed RB51 strain in their milk. So as Maria said, there were 3 cases of the abortus vaccine strain RB51 in the U.S. since 2017. The first case traced to a Texas Jersey cattle herd dairy, and these are Jersey cattle. In case you don't know what they look like, they're really cute. And there were a lot of people exposed. The New York case, when we traced that one, Uttermilk, what they had online as being their offices were just empty fields and not offices. The owner was out of the U.S. There was a lot of, anti-government, government control screed on their website. We even tried a sting operation. New York Department of Health did that, and we had no luck tracing the source dairy herd. They had advertised that the milk was from Amish farms in Pennsylvania and New Jersey, but neither Pennsylvania or New Jersey could trace anything without more information from Uttermilk. States have different regulations on raw milk, and these are states that absolutely don't allow it, and then states that allow it in different ways. And on here, one of them you'll see is a herd share. And in a herd share, you become part owner of the cow, and by state law, you can consume your animal's own products, including raw milk products. One of the other issues that this map doesn't show, I think, yes it does, I'm sorry, and the kind of the pink is raw milk sales for pet food. And so people may be allowing it in states for pet food, and then the humans consume the raw milk illegally. In states where the retail sale is legal, a lot of those states require a whole herd test for Brucella abortus. Well, that's great, but the reason the RB51 strain was developed, vaccine was developed, was that the cows don't cross-react on a blood test. So while we require whole herd screening to sell raw milk, the tests that we run on the cattle don't look for shedding of RB51. Who has legal jurisdiction over raw milk? Well, FDA regulates dairy products. And when this issue first came about in New Jersey, and they were distributing milk in New Jersey where we don't even allow the sale of raw milk, we approached FDA and said, you guys regulate dairy products. And they said, that's really low on our list of priorities. We have a lot bigger stuff to deal with. So in our case, it became a One Health issue very quickly. The CDC regulates human health. USDA regulates the distribution of RB51 vaccine. It can only go to accredited veterinarians. It's very controlled. We also regulate the animal health. Being persistently affected with the vaccine strain doesn't seem to make cattle sick. State agriculture, they also protect animal health in their states, as well as distribution of product. The local and state health departments were involved. Then there was internet advertising of some of these illegal activities, like saying, we'll bring and deliver the milk to you in New Jersey, even though that's illegal. And then the FBI and CIA got involved because the abortus is considered could be a weapon of bioterrorism. So again, when we looked for Uttermilk, we couldn't find any processing. We couldn't find any headquarters. They did advertise some of their drop-off sites, and we were able, FDA and the state health department were able to catch them delivering this raw milk, and they cultured it and did not find any brucellosis in the milk that they cultured. Investigations of Uttermilk are still ongoing because not only were they distributing raw milk across state lines and selling it in states where it's not allowed, but they also were doing the same with meat products. So in November 2018, a child became ill in New York, and at first the parents were kind of reluctant to cooperate, but then they finally did, and they said they had bought the milk directly at a farm in Pennsylvania. And raw milk sales are legal in Pennsylvania if the herd is certified with the state. So the health department reported it to the Pennsylvania Department of Agriculture on December 21st, and a quarantine on the raw milk and the source form was placed on December 22nd of 2018. It was traced to a herd, and I'm using herd names here because they were in press releases, called Miller's Biodiversity Co-op in Lancaster County, Pennsylvania. They were advertising widely on the web and also about selling organic products and raw milk. Very small dairy herd, only 48 cattle, most of which were Jersey cattle, and 2 were Dutch belted dairy cows. Even though I'm a vet, I had never heard of a Dutch belted dairy cow, so that's that black and white cow on the bottom. There is a Dutch belted beef breed, but I hadn't heard of the dairy one. The cows didn't have any problems with abortions or infertility, which are signs of brucellosis infection, and the owner said, I don't vaccinate my cows. But since 2015, he'd purchased 14 Jersey cattle and added them to the herd, and then he also had purchased the Dutch belted cattle. He didn't know whether the cows he had purchased had been vaccinated for brucellosis or not, and a few of them had vaccine tattoos, but none of them had vaccination ear tags. The really interesting thing was, in further questioning the owner of Miller's Biodiversity, he had previously sold milk to Udder Milk, and that included the time frame of the New Jersey case. And then he had a falling out with them and stopped selling to them. So when you're going to go to the farm, who are you going to test? Well, you kind of want to test everybody, but gosh, if he says he doesn't vaccinate and most of his cows were born on the farm, you're going to start with the most likely suspects, the 14 purchased cattle. They were all in lactation at the time. And so state officials, including the state vet at the time for Pennsylvania, went out and took milk samples from each quarter of all the milking cows, and then also serology. Eventually, the whole herd was tested by milk culture or serology. And we found one cow that was shedding RB51 in her milk, and this is a picture of her. She's a Jersey cow named Felicity, and I think she was 7 or 8 years old at the time. And it was detected in the samples at very high levels. So we were quite surprised by this finding that her right front and right rear matched the profile of the 2017 New Jersey human isolate, and the left front and left rear quarters were shedding RB51 that matched the New York. First, it's really hard to even get these things traced back to the farm and the individual cow, and now we found one cow that was shedding different strains involved in 2 different human cases. So we were surprised. When we traced Felicity back, first her ear tag traced to a farm in Iowa, and it was an RFID tag that you read with a microchip reader. That didn't make sense because the man in Pennsylvania had said he bought the Jersey cattle from someplace down south. So the animal ID coordinator for Pennsylvania went out, rescanned the cow's ear because, as I always say as an epidemiologist, if the puzzle piece doesn't go click, something's probably wrong and you need to look again. So the AIC looked again, and 2 of the numbers had been transposed on the test chart. Once we got the correct number, the cow did indeed trace to a Virginia herd, and the veterinarian for that herd still had the vaccination records for this cow, and she was vaccinated properly at 11 months of age. So why might it matter that Felicity was vaccinated at 11 months of age and not 5 months of age, say? Why are we seeing it more in Jersey cows? Well, one, maybe more Jersey cattle are used to produce raw milk for consumption. It's higher in milk fat, and a lot of people like it better. Also, Jersey cattle mature much faster than Holsteins. So a Jersey cattle will go through puberty when it could be bred at 10 months of age and have its first calf between 22 and 23 months of age. So that's 10 to 19 months from vaccination to calf. versus Holsteins are going 13 to 22 months between vaccination and calving. The other thing is that there have been studies on other diseases that show that Jersey cattle's immune systems might just be different than Holstein cattle. And Holsteins are the black and white cows that produce most of the milk that we drink in the U.S. So it may be that Jersey cattle, some of them clear the RB51 and maybe some of them don't. We don't really know at this point. And the prevalence of shedders is really unknown because the only cases we found so far have been the ones where humans have become ill, and most milk is pasteurized. So what are some of the One Health issues then that we had to address? USDA has been telling accredited veterinarians not to calf foot vaccinate unless the herd is in the greater Yellowstone area or sells to a state like California that still requires it. That word has been slow to get out there. We're trying to get it out there more. State animal health officials are also telling bovine practitioners, vets that work on cattle, the same thing, and they're also recommending that they stop using RB51 vaccine in calves that are intended as adults to produce raw milk products. We need the help of physicians and the CDC to keep telling people the risks of raw milk, and physicians to maybe recognize Brucella infection in some of these people. I don't think it's something that, I mean, I sure wouldn't think of it first if I were a physician, so I don't think a lot of physicians probably would. And then the CDC and USDA are both doing ongoing research into the shedding of RB51 in milk. And Felicity was purchased by the CDC and now lives in Georgia, and they say she's a very nice cow. So the other interesting thing with some of this was who's enforcing the rules that are already there. The Pennsylvania farm where Felicity lived did not have a permit to sell raw milk, which Pennsylvania requires, but they were doing it. And not only were they selling raw milk, they were advertising it on the internet and really pushing to sell it across state lines. New York Uttermilk was selling milk in New Jersey illegally, not directly from farms in New York, as to consumers in New York, as New York requires. So who's enforcing this? Who's keeping an eye on what's going on the internet? Pretty much not many people. So some of them One Health issues, who's tracking the internet advertising and sales and making sure that producers are complying with state regulations? I think that's a One Health issue that we have to decide who's going to be doing that. Technically, it should be the FDA since they regulate dairy products, but again, they said they have bigger issues to deal with. Who's tracking and investigating illegal sales of raw milk when they cross state lines? Unless somebody gets sick, probably not a lot of that is going on. What is the prevalence of RB51 shedding in milk? Is this a big problem? Should we not be using that vaccine? You know, we can say it's rare for it to spill over to people, but we don't know how many cows are shedding it. Again, pasteurization would kill it. And then what is the prevalence of RB51 human exposure and infection in the U.S.? You know, how many cases from people consuming raw milk did we miss? How about, you know, dairy farm workers and milkers and milk haulers and people who work at the pasteurization plants that might be exposed to raw milk before it's pasteurized, as well as those consuming raw milk? And then this is just a website from a group that promotes drinking raw milk, and I thought it was interesting. You know, they have the picture of the little child with milk around its mouth and how healthy it is, but they don't have the picture of the kid on IV fluids in the hospital. And that is the end of my talk. So we'll take questions at the end. Thank you.
Thank you so much, Dr. Serafin. At this time, we have a few moments left for questions. If you'd like to ask any questions for our presenters, if you haven't already, please call in 1-800-593-8936 and enter participant passcode 9611836. Press star 1 and give the operator your name and affiliation. Please name the presenter or topic at the beginning of the question. Chelsea, do we have any questions on the line yet?
I'm showing no questions at this time. One moment as we look for further questions.
Okay, we're going to have one more few more moments in case there's a question, and then we'll finish up the call. Okay, it doesn't appear we have any questions today. If you do have a question,
we do have one question, or two questions right now. So the first question is coming from Shane. Shane, please state your name as well as your affiliation. Your line is now open.
Yeah, hi there. Thanks. This was for Dr. Serafin. I was wondering, this is Shane Hessing with Wildlife and Parks in Kansas. I used to milk cows on the farm when I was little, so I had an interest in this with Jersey cows. What's going to be done with all the Jersey cows known to be vaccinated with RB51?
Well, as long as their milk is going to pasteurization, it's probably safe. I mean, yes, would the person doing the milking possibly get splattered with milk or someone picking it up? Yeah, maybe. I think the first thing we have to do, though, is figure out, is there something about Jersey cattle that caused them to become persistently infected and shed it? And then what is the prevalence? You know, if it's 1 in 10,000 cows or 1 in 100,000 cows, how we're going to act is different. And then other really than the greater Yellowstone area, and if you're selling to states that require vaccination, the biggest thing is to get veterinarians and producers to stop vaccinating their cattle for B. abortus. Did that answer your question, I hope?
Yeah, I grew up on a farm. We milked too, so I don't know. Small was mentioned for 50, but I don't know what 2 cattle ultra small.
Yeah, and I milked, in order to get into vet school, I milked cattle, but I milked Holsteins for a summer. But I tried the raw milk, and I tried colostrum, so.
So we drank all that growing up, and we never vaccinated those cattle. So,
that's
but
good.
This is back before you had all these vaccination types too.
Right.
So I guess my question was, there are a lot of operations that do milk maybe 1 or 2 still for family use, and those aren't being pasteurized.
Right, and so I think that's part of the education piece that both USDA and CDC need to do to people, that there is a risk from drinking that raw milk, not just for brucellosis, but for other diseases as well. And, to know everybody accepts different levels of risk. What may be too risky for me might be perfectly safe for you. So I think the thing is to educate people what the risk level is and then let them make decisions for themselves. But in those cases, I think for the vast majority then of people that have a couple cows and milk for their own use is to not vaccinate them, or to think about some small home pasteurizer so that they're not getting some of the other bacteria, which are much more prevalent from drinking raw milk.
Right. Hey, thank you very much.
You're welcome.
I'm afraid we don't have time for the other questions because we're already past time, 3 o'clock. So I'm going to go ahead and wrap up the call. Continuing education instructions are available on our website at cdc.gov/onehealth/ZOHU/continuing education. Course access code is OneHealth2019. To receive CE for today's webcast, complete the evaluation by September 9th, 2019. A web-on-demand recording of today's call will be posted online by September 10th, 2019. To receive free CE for the web-on-demand video of today's call, complete the evaluation by September 10th, 2021. Please join us for the next ZOHU call on September the 4th, 2019. Thanks again for your participation, to all of the presenters for their excellent presentations. And let's see. Yep, thank you. Thanks again for your participation, and this ends today's call.
Thank you, and that concludes today's conference. You may all disconnect at this time. Speakers, please stand by for your post-conference.